Magandang umaga! Welcome to the Asian Virtual Conference on Multidisciplinary Research. I hope that you are all doing right during these very hard times of our lives. My name is Charles Sandro Vasquez, and I will be presenting to you our thesis for this day, entitled Diagnostic Utilization of Urine 1,5-anhydroglucitol as a Non-Invasive Predictor of Serum 1,5-anhydroglucitol in Diagnosis of Type 2 Diabetes mellitus using enzyme-linked immunosorbent assay. Here are my co-researchers in this group. Today, we have four main agenda in this presentation, and we shall begin with the background of the study. Diabetes have become a prevalent and major health crisis in this generation. According to World Health Organization in 2018, diabetes is a chronic progressive disease characterized by increased blood glucose, which can further continue to complications such as cardiovascular disease and even to premature death. There are two types of diabetes, type 1 and type 2. Type 2 is also known as diabetes mellitus. According to Bennett in 2006, up to 9 out of 10 cases of diabetes are classified as type 2 diabetes, and 12.8% of that is a global death rate according to the study of World Health Organization also in 2018. With that, different kinds of biomarkers were used in the clinical practice in diagnosis of type 2 diabetes mellitus, which includes FBS, oral glucose tolerance test, and fructosamine. A biomarker known as hemoglobin A1C is considered as the gold standard in screening and monitoring cases of diabetes, which is according to the study of Ha-Yun Yu et al. In 2015. Some of the major advantage of hemoglobin A1C includes no fasting requirement for the patient's prior blood collection, and most especially, hemoglobin A1C reflects glycemia on average 2 to 3 months, which is described by the study of Dabrowska et al. In 2012. Even though labeled as the gold standard in the clinical practice in the diagnosis of type 2 diabetes mellitus, hemoglobin A1C was subject of certain drawbacks in certain conditions. The average glucose levels potentially excludes important hyperglycemic excursions that may be balanced out by hypoglycemia. Wright, in 2012, find conditions where hemoglobin A1C yields false results, both high and low. So some conditions include iron deficiency anemia, hemoglobinopathies, hemolysis, reticulocytosis, and many other more. Those kinds of major disadvantage prompt several of our researchers in the past, including Dungan et al. In 2016, to suggest a new alternative biomarker that would robustly reflect postprandial glucose excursions that would be useful in the diagnosis and management of patients with diabetes. This alternative is also known as the 1,5-anhydroglucitol. 1,5-AG is also backed up with several other researchers in the past, including Welter et al. In 2018, who described it as a naturally occurring polyol, which is a stable biomarker that detects hyperglycemic excursions of diabetic patients. Dabrowska et al. In 2012 said that it can be determined by the balance between oral intake and urinary excretion. On the other hand, Stratman and his co-researchers finds that a significantly lower concentration of serum 1,5-AG can be seen in diabetic patients versus the normal and healthy individuals. Thus, this research would like to prove that whether or not the presence of urinary 1,5-anhydroglucitol can be utilized as a non-invasive biomarker in the diagnosis of type 2 diabetes mellitus.
A blessed day to everyone. My name is Millie, and I am a member of the research team of 1,5-anhydroglucitol. Criterion of the participants was established to target specific standard and to establish a well-organized research process. The residents of San Agustin 3 was divided into two categories, which we have our positive control, where it's composed with individuals who aren't pre-diagnosed with type 2 diabetes mellitus or hyperglycemia. Also, they are not included in the list of diabetic individuals who are receiving medication provided by the City Health Office of Dasmariñas. And most of them has a normal BMI unit or the body mass index. while the negative control are the individuals who has been diagnosed by their physician with type 2 diabetes mellitus. And these individuals are included in the list provided by the City Health Office. All participants was selected between 18 to 70 years old, male and female, who have agreed and signed the written consent provided by the researchers. All participants under negative control advised not to take or inject any medication that would alter their sugar levels. Both participants under both categories was advised not to drink alcohol or smoke, cigarette or e-cigarette, or anything that contains nicotine for at least 24 hours. 44 volunteers, 22 in positive control and 22 in negative control, both urine and blood were collected in the early morning to ensure real-time concentration of 1,5-anhydroglucitol. For the time being, blood extraction in our diabetic participants was made prior to insulin and oral medication. After extraction and collection of samples, the researchers proceed to sample preparation that was held in EAC Medical Technology Laboratory, where the blood was allowed to stand for at least 2 hours to coagulate. Both blood and urine was centrifuged at 3,500 RPM for 20 minutes. After centrifugation, we separate the supernatant in urine, and serum was separated from the whole blood. Both samples was kept at negative 20 to negative 80 degrees Celsius for storage. Then after a week, both samples were towed to room temperature and recentrifuged at 3,500 RPM for 20 minutes. Now I'm going to walk you through in experimentation proper. In this study, we used Glycomart, an enzyme-linked immunosorbent assay, or ELISA kit, specific for 1,5-anhydroglucitol. Reagents and pre-coated well were all provided by the manufacturer for the specific assay. Okay, as we can see, we have a 96 well of pre-coated antibodies specific to 1,5-AG. We have allocated 5 wells for the standard points and 1 well for the blank concentration for quality control purposes. A measurement of 50 UL for each standard, blank, and samples were added to the pre-coated wells. After that, 50 UL of detection reagent A was added to each well immediately. The plate was sealed using a plate sealer to gently shake and mix the following solution by the aid of a microplate shaker for at least 1 minute to ensure the equal distribution of the reagents. Following that, 1 hour of incubation at 37 degrees Celsius was done to allow the solution to mix and settle. After 1 hour of incubation, washing procedure was done twice using an automatic microplate washer. The removal of the remaining liquid by inverting the plate was done, and it is blotted against the absorbent paper. 100 UL of detection reagent B was then added to each well and sealed with a plate sealer to gently shake and mix the solution. The plate was incubated for at least 30 minutes at 37 degrees Celsius to allow the solution to settle down. Washing procedure was done 5 times using an automatic microplate washer. The remaining liquid were removed by blotting or decanting the plate against the absorbent paper, and also we needed to ensure complete removal of liquid at each step. This point of the procedure was critical because insufficient washing can result in poor precision and false elevation in absorbance reading. And after that, a measurement of 90 UL of substrate solution was added before covering the plate with the plate sealer for 20-minute incubation at room temperature. As we can see here, the liquid turned blue by the addition of substrate solution as it settles down. Immediately followed with 50 UL of stop solution in each well, and the color of the solution changed from blue to yellow. After all assay preparation, microplate was immediately processed and read through a microplate reader at a 450 nanometer wavelength. Any droplet of water around the well and fingerprint on the bottom were removed. Absence of bubbles on the surface of the liquid was checked to ensure to obtain accurate results. Absorbance was recorded. Concentration of 1,5 Ag was computed based on the absorbance values recorded.
Now we're here in the most crucial and important part of the study, the discussion of results. The tables listed to you right now strongly finds a significant variance in 1,5-anhydroglucitol concentrations in serum and urine for both control groups. These numbers are parallel and consistent with the findings of Akanuma et al. In 1988. 1,5-Ag is largely retained in the circulation and only partly excreted in urine under normal conditions. This observation suggests that 1,5 Ag excretion might be promoted by a high blood glucose concentration. The mean concentration for urine 1,5 Ag from normal individual is six-fold decrease against the urine from diagnosed type 2 diabetes mellitus patients. Similarly, a seven-fold increased normal serum is noticeable against the 1,5 Ag levels seen in diabetic serum. A p-value of 0 indicates a significant difference in the levels of both urine and serum 1,5 Ag between normal and diabetic individuals, thus saying that there is a correlation between serum and urine 1,5 anhydroglucitol, making it as a predictor of serum 1,5 Ag in the diagnosis of type 2 DM. To answer the diagnostic capability of urine 1,5 Ag, yes, it is potentially capable of diagnosing type 2 DM using a linear regression that the researchers were able to derive as the best fit predictive model for urine 1,5 Ag. Based on the analysis of ROC or receiver operating characteristic curve, it was demonstrated that the diagnosis of diabetes using 1,5 Ag concentration in urine can be a promising, non-invasive alternative to the existing methods, especially accounting to a 95.5% accuracy, sensitivity, and specificity. Results are consistent with the findings by Ying et al. In 2012 and the studies of Shirasaya et al. In 1999. Finally, it is with great joy that we say that the researchers were able to pin down three good conclusions at the end of this study. First, there is a significant difference in levels of serum and urine 1,5 anhydroglucitol between the diabetic individual and the normal individual. Second, through a simple linear regression, urine 1,5 anhydroglucitol concentration is a possible predictor of serum 1,5 anhydroglucitol. And lastly, urine 1,5 anhydroglucitol can be used as a biomarker for a non-invasive method that is capable for diagnosing type 2 diabetes mellitus, proven in the study showing a high sensitivity and specificity of 95.45 respectively. We recommend to the future researchers to compare 1,5 Ag values of men and women from different age groups and other conditions and to correlate the values according to different variables. And lastly, to correlate results of 1,5 Ag to the current gold standard in the other markers of diabetes, which are hemoglobin A1C, fructosamine, and 2-hour oral glucose tolerance test. On behalf of Melin Besana and my co-researchers, I would like to say thank you everyone and God bless.